We have guidelines to go by in private practice and everything, and they've come out and redid the guidelines how you treat a kid that wheezes and has asthma. Can you sort of like this cover in a little, make it a little bit less complicated so we get into some of these new guidelines we're about?
The NHLBI, the National Heart, Lung, Blood Institute from the National Institute of Health, has recently, just 1 month ago, in August of 2007, released the newest guidelines for the treatment of asthma. And these guidelines are a step beyond what the previous guidelines of 5 years ago taught us. Asthma has two pieces of its problem. It has how severe the problem is, and then it has how well controlled the symptoms are. And the guidelines really help us take a look at both parts of this problem. In looking at how severe the problem is, we break this down into how sick the child is now, as well as what the risk is for them having problems in the future, so-called the impairment domain and the risk domain. In taking a look at how sick they are now, we look at how often they're wheezing every day or every week, how often they're using their medicines, specifically their reliever medications, if they're waking up at night, if they're able to exercise and play with their friends properly, if they're able to attend school and work. We also look at their lung function test to get a sense of how well the lungs are working. Because sometimes children seem well, but when you do the lung function test, it shows that they're actually sicker than what they appeared on the surface. Once you start with how severe they are, that will give you your starting point in which medications should be used. And the medications would include inhaled corticosteroids, leukotriene modifiers, long-acting beta agonists, as well as a group of other medications that we occasionally use in specific situations. Once that patient's severity and starting medication has been instituted, you then need to re-evaluate that patient on a regular basis. Re-evaluation should occur anywhere from 1 month to maybe as long as every 6 months, but the usual recommendations are roughly every 2 to 3 months, at least once every season, so that we can judge whether our first round of medications are successfully controlling the symptoms. If the patient is using their reliever medicine more than twice a week, if they're waking up at night twice a month, if they're having difficulty with exercise, where they're coughing or getting out of breath easily, if their lung function tests aren't normal, these are all signs that the patient is not well controlled. And if they're not well controlled, we then would need to step up in their medication, either to increase the dose or add a new medication. If they are very well controlled for anywhere from 3 to 6 month period, that would also signal that we may be able to lower their medication safely, trying to minimize how much medicine the child is on, while not increasing their risk of developing more serious symptoms in the future.
One of the reasons some people don't get well controlled is when they use inhalers, they think they have medicine and it has gas and no medicine. Is that true?
It is true. Inhalers have the advantage of being able to deliver medicine in a simple fashion, but they have a disadvantage in that we don't always know whether medicine remains in the inhaler. A very nice study was done a number of years ago where patients brought their inhalers in and the actual amount of medication was measured, and it was found that roughly 20% of the patients who thought they still had medicine left in their inhaler actually had inhalers that had no medicine left, merely the gas propellant. This is why newer medications include counters so that we know how many doses are left in the device, and as we get down to the end of the device, we can then know to refill our prescription. We should also keep track of when a canister is started, because we know that there's roughly 1 month's supply in an average canister, and if we count backwards from the starting date, we'll know when it's time to refill our prescription. When in doubt, it's better to get a new canister of medication than to be pumping on a canister that's empty.
So a 1 month rule is a pretty good rule. Most of the time it's a month, get a new one.
If you're using the medicine in the way that's recommended by the physician, then 1 month per canister would be the average.
In fact, the albuterol inhaler only has 200-meter doses, and we give 2 puffs 4 times a day. You're out at 25 days.
Exactly. It does not even last a month. Now, ideally, we shouldn't be needing the albuterol 2 puffs 4 times a day. In fact, if you're taking it that often, then you really need to adjust your controller medications, since albuterol is a reliever and should be used more on an as-needed basis. Therefore, once a month refill is the optimal, and one of the guides that a physician can use that you're not under good control is if you're renewing your prescription more often than a monthly basis.
So it seems that the new guidelines are trying to get better control, more effective control. But a lot of schools are still giving us these old guidelines. Should we look at these old guidelines with the red, green, blue, or throw that out, or should we even look at them at all?
Well, many schools are still using the old asthma action plan, which was an attempt to try to organize the patient's treatment during emergency situations. Now that the new guidelines have been released, I think that newer, more appropriate action plans will begin to be instituted. In general, the action plan should be very simple. The patient should be on their baseline controller medication. If they're having symptoms in school, then they take 1 dose of their short-acting beta agonist, either albuterol or Xopenex. If that's not sufficient, then my recommendation is that they see their physician or go to the emergency room so that the more detailed treatment can be implemented and the cause of the symptoms can be investigated.
I thank you very much.